Ross, thank you. We'll finish up this session with John Pandolfino, and John's going to talk about novel treatments for LPR. John?
Well, thank you very much. I'm very excited that the attrition rate wasn't very high. I also want to just briefly thank Reg and Kate for really working so hard in this meeting. They really put a lot of effort in. I know the board had worked very hard, but really those two together really pushed this thing forward. And it gets down to the whole issue about collaboration. I do want to make note that I was obviously not part of the planning committee for the talks, because if you look at my talks, I got an LPR talk on novel therapies after people basically reviewed all of my slides. And I've also got to talk about post-fundal ligation complications. So obviously I got the short end of the stick, and I thought I was friends with Felice. These are my conflicts, and they're important because obviously they're involved in this particular disease state. But I want to start with a disclaimer. And it was really heartening to hear all the trouble that everybody else was having, because I think this is an important thing, that when we come up here and we talk to you about this, and I think Joel made that point too, that he spent 40 years looking at this, and I really struggle with these patients. I really don't have a good idea of what's going on in most of them. Unfortunately, I see the patients after Blair takes those patients who are good candidates or have axial reflux, and then I get the residue. So that's not great. And I have to tell you that I rarely make people much better when I think about the underlying symptoms. But, I've made a lot of good friends with my ENT colleagues, Mike Beauvais, and now I can get a cricopharyngeal myotomy pretty much whenever I want. So that's my kind of disclaimer. Now, you've seen kind of this talking around this symptom complex. And I love Ross's talk, very interesting. And I'll tell you, Ross, that I can tell a lung transplant patient pre-op evaluation before I even open the study. You see these deep blue stripes right down the esophagus, and those are those inspiratory efforts. And as you expand it, you see it there. And it's pretty amazing. We looked at this probably in COPD and restrictive lung disease and saw that this was a very important dynamic. I mean, if you think about it, the chest is a vacuum, and it's really just sucking things up into the chest, and it actually does affect peristalsis. And I'm happy that you brought that up about the peristalsis improving, because when you have those negative pressures generated, you literally are pulling the esophageal lumen apart. The esophagus has to fight that negative pressure to close the lumen. So a very interesting observation. Now, in terms of what we see with these patients, there are a lot of different extraesophageal syndromes and symptoms. When you look at these, cough, laryngitis, throat clearing, people are implicating dental cavities now, otitis media, and it'd be very difficult to think that one treatment's going to treat all of this, especially when you have a practice like mine, where after people have been kind of sifted out with objective reflux, I'm seeing the patients with pretty much everything negative. So it's really important to realize that, and I know other people this afternoon have touched upon some of these potential novel therapies, but we have to use different things, and we have to use different tests, and all of these things are complementary. And I love the picture of Blair's team, because I think that's really the essence of developing an esophageal program, an esophageal practice, is bringing everybody together. We heard this. I still love showing this slide, though. Over $50 billion on this particular, look at where it is with cancer. That's insane that we spend this amount of money. But when you think about how difficult this is and how many times these patients get evaluated, it's pretty amazing. And much of this is due to PPI therapy. And I'll tell you, probably one of the best things that happens in my clinic is when I take people off PPI therapy. I actually have 2 grants that are particularly focused on trying to figure out how to get people off PPIs and what is the physiologic background that helps us predict who we can get off PPIs. And I think that is an important component of what we try to do with these people, because I do think this empiric trial that we do over and over is problematic. I believe that when you actually look at these patients, you need to understand that this is a very complex disease. And I think Blair showed this probably much nicer than this slide will. But I do think that when you look at the lack of a gold standard, the deficiencies in the diagnostics that we have, the fact that we have poor treatments for specifically the ones that don't have overt reflux, we're in a little bit of trouble. And then, of course, there's all these other things that are associated, and that long list that Blair showed was very impressive in terms of what can actually cause these symptoms. And it's amazing when you think about this and you go to an ENT and you talk to them about these symptomatology of laryngitis and hoarseness and throat weakness, and it's pretty amazing, the litany of that. And we heard a little bit about the reflux theory and the reflex theory. I do think there's importance to this. I think there's a very big difference between the patient that is microaspirating, and I think there's a very big difference between the patient who has a reflex-mediated problem in terms of cough or these symptoms. And I think not just a reflex that's mediated via the esophagus to the larynx and the pharynx, but also a hypersensitivity that has evolved in the larynx and pharynx. So once again, not just a reflex that's mediated in the esophagus related to reflux, but also another reflex that is stimulated via hypersensitivity. And just like everybody else, I'm showing an algorithm with an empiric trial of PPI in this group. It's interesting because my mentor, Peter, published a really nice paper where he reviewed all of the data from the PPI trials and showed that when you actually looked at the symptoms, the response to therapy with cough, laryngitis, and hoarseness above placebo was minimal. But yet, this is the common standard approach. And what's the definition of insanity? When you do the same thing over and over and you expect a different result, right? We keep giving the PPI, keep hoping that they get better, and they don't. When you look at the data, not very encouraging. And I think that's really where the ACG guidelines, I thought, made a pretty reasonable kind of assessment of the situation and gave at least some guidance, meaning that, if you don't have what appears to be reflux, the typical reflux symptoms with these symptoms, and before you start thinking this is reflux and going ahead and giving them PPIs for 12 weeks, and you know what happens, they get 12 weeks of a PPI, and then they come see the GI doctor, he switches them to a super PPI. That never works. And then they go see another doctor because they were unhappy that they didn't get, that person didn't help them. Then they get placed on a different PPI. And it's maybe a year or 2 years later, and yes, the patients are frustrated and depressed. Even with fundoplication, a very effective tool to reduce reflux, the patients do better when you see the patients who actually have overt acid exposure. So we're in trouble, especially when you remove the patients who have a positive reflux test or a positive Demeter score. Those are the most difficult, challenging patients. And that's where, I was told that now this contraption, as I will say, Reza, is now called the reflux band and is now available over the counter. But it was originally the conceptual model of Reza. And this is really a nice tool because I think when you think of the microaspiration component that many of these patients have, we really don't have a device to augment the upper sphincter. We don't have a tool or a ring, and this was really a beautiful concept that Reza studied over many years with his physiologic reflux, where he was able to design something where he could apply a very subtle cricoid pressure that wouldn't inhibit the patient from going about their normal daily activity. And I believe that this is now even being able to be modified via a Bluetooth component, but you can apply that pressure. And when he looked at the data, and certainly, you can be criticized because this was not a randomized controlled trial, they did show a very important improvement in symptoms, in terms of the RSI, and I think that's very important. And I will tell you that in my clinical practice, this is something that I do use in patients who are at risk for aspiration. In fact, one of the studies that we first thought to do was in a scleroderma population who would be suffering from this with pulmonary fibrosis and microaspiration and using this. And outside of a few people who thought it was a little bit uncomfortable, it seemed that many of these patients had a symptomatic improvement. So certainly, I think when we think about novel therapies, that this is one of the state of the art. We're moving this technology that we applied at the lower esophageal sphincter and trying to think about this in terms of the upper sphincter. Well, what about medications? Well, as I mentioned, went a little bit too fast there. We certainly want to target the reflex, we want to target hypersensitivity, and we want to target hypervigilance. And I'll talk a little bit more about hypervigilance. But essentially, the main medicine that's come out, especially in cough, because baclofen does have a mild antitussive component, is baclofen for cough. And I will tell you, it is not a very effective medicine in refractory reflux with heartburn or chest pain, but I have some patients that actually do okay on baclofen. I typically start them at a very small dose, 5 milligrams TID, make sure they're not falling asleep. As they continue, we can increase that to 10 TID. I don't really go up to 20 TID very often because then it really impacts their quality of life. And one thing we do know is that you can reduce TLASRs by putting people to sleep. And certainly that medicine can work in a dual way, both centrally and peripherally. So baclofen is a little bit of an option in patients with cough, and certainly something that you can try. I think more importantly, though, I like to focus on the fact that there is a brain-gut, brain-larynx, brain-everything interaction. If your brain's not working, you're not going to feel symptoms. And we actually look at the construct of a triggering event, how it is mediated, the response that a patient has, and then how it affects their quality of life. There's a lot of places there where we can intervene. I thought one of the coolest studies that was ever done in terms of globus or any of these hypersensitivity studies was a study by Ian Cook where he basically inflated a balloon or did electrical stimulation in patients who had typical symptoms or normal controls, and then patients with globus. And he could show that if he blew a balloon up in the esophageal body or actually did electrical stimulation in the esophageal body, globus patients would localize it to their throat, whereas normal controls would actually feel it where it was. So this aberrant discrimination as to where the symptom is coming from is extremely important. And that's really been the impetus for us to start to use things like cognitive behavioral therapy and also hypnosis. Because really, the most important thing that you can do with many of these patients who are not candidates for anti-reflux surgery is to help them cope with this disease, to let them know that they can still go out, still enjoy a normal life. And really focusing on these patients and having them make the appropriate decisions and deal with their symptoms is extremely important. If you think about it, people sit at home, they develop heartburn. One person runs to the emergency room, another person takes some Tums and goes to sleep. It's very different how people will respond to symptoms, and that drives healthcare costs and utilization. How does hypnosis work? It makes people forget about the discomfort. It shifts their attention. We know that there are parts of the brain that are located right next to the cough center that deal with chronic pain in the anterior cingulate cortex, that deal with this transition, and there are long descending fibers down to the esophagus and the larynx that can be manipulated. And by using deep relaxation and by using these metaphors to essentially trick the brain, we can make patients not feel this as much. The underlying pathogenesis doesn't go away, but they may not clear their throat as much. They may not worry about the hoarseness. They may not cough as much. And this has been a very effective tool in globus. In fact, I will tell you, we published a paper, small one, uncontrolled, but 9 out of 10 people got better with globus, with hypnosis. And I'd say that now that we've been doing this for a while, it's probably more on the order of around 60 to 70%, but globus is pretty tough, especially when there's nothing else that you can attack. So hypnosis is a very effective therapy for those particular patients. I do think neuromodulation is extremely important. There's a beautiful study by Dan Sifram that did show that if you use citalopram, you can certainly improve the threshold for sensitivity in some of these patients. So there's a very nice SSRI with a very mild side effect profile. And when I tell people with neuromodulation, pick a couple of medicines that you're comfortable with. They all work basically using the same approach. They affect the nerve, they affect hypersensitivity. And in my practice, I like to use amitriptyline, especially for patients who have hypercontractility in their esophagus. And I like to use the SSRIs for people who have maybe some ineffective esophageal motility. But overall, I use them interchangeably. Now, we heard a little bit about Neurontin. I'm not going to talk too much about that. I will tell you, though, that wasn't the Northwestern experience. That was a UNC experience. The Northwestern experience is not that great. We have a lot of people complain about the medicine's side effects, but certainly something worth trying in chronic cough. So in the end, I don't think I've given you too much in terms of novel therapies, and I certainly did not help Joe Richter much. He barely stayed awake. But in the end, I think this is the beautiful thing about the American Foregut Society, that we can bring everybody together and we can start working on these problems together, because I don't think we're doing justice to these patients who are suffering with this particular symptom. Thank you very much.